Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is CMS requirements of participation for long-term care. My name is Robin Malik, and I will be facilitating today's meeting. Please note, the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary, depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. And now, to get us started, please welcome our Clinical Director at Direct Supply, Liz Jensen.
Thank you, Robin. Hi, welcome everyone. Thank you so much for joining us today. As Robin said, my name is Liz Jensen. I'm the Clinical Director here at Direct Supply. As all of us are aware, November 28th of this year, the phase 2 of the CMS requirements of participation will go into effect. These changes are large and all-encompassing, and we have decided to provide you with some information today that takes more of a very focused view into these requirements, specifically related to clinical equipment and the care environment. You'll see on the screen here today our focus for today, and these are our objectives. We'll be reviewing selected FTAGs and surveyor guidance that addresses care environment and clinical equipment. We'll discuss examples of how decisions on care environment and clinical equipment may impact care outcomes and compliance. And we'll explore ideas for improving the care environment and utilization of clinical equipment that supports competent, person-centered care delivery and effective operations management. This webinar is a little bit different from the webinars that we've done in the past. This webinar will be a little bit longer. It'll be about an hour and a half long. And I have invited a few of my partners here at Direct Supply to join us in some conversations about these topics today. But first, before we get into that part of the webinar, I wanted to share just some thoughts with you. I've been with Direct Supply for about 5 years. Prior to joining Direct Supply, for about 20 years, I worked for large providers in the industry, and much of my experience has been related to clinical program development and quality improvement initiatives, helping providers, working with hundreds of directors of nursing, administrators, regional clinicians, and operators to improve quality care and outcomes. As I was reading and digesting the almost 700 pages of this guidance, it's clearly overwhelming and a lot to take in. And I was struck by the thought that of a few ideas that I wanted to share with you today. In my years of experience in working with providers, I've found that the formula that I have here on the screen here today is being very effective in helping providers both focus and simplify the way that they're providing care and services and meeting these requirements. You can see in the very large circle that the basis of all of this and how we're developing programs are really rooted in clinical evidence and best practice. And I would work with providers to really focus on what did we understand to be best practices today? What is the evidence telling us about how we best provide care? And over the years, we saw many improvements as a result of focusing on the research and focusing on improving practice related to that. Once the providers could really understand and focus on implementing best practice, then we would really start to look at reducing risk. So where were we seeing risk? Risk related to care, risk related to injuries, risk related to poor documentation or that would potentially result in issues with litigation. So we would work to continue to hone our best practices and reduce risk at the same time. Next, you can see embedded in there, we would really work to try to simplify and to make the process for implementation easier. And my experience has been that if we can't make a process simple enough and easy enough to follow and for staff to be able to integrate it into their practice, their daily practice, and to be able to get everything done that they need to get done during the day, it just wouldn't work. And so being easy to use was very important and critical to implementing these best practices. Finally, in our experience, we found that when we focused on clinical evidence, when we focused on reducing risk, and we focused on making things easy to use and being able to easily teach our staff how to use them, that very often regulatory compliance just followed. This was a interesting and experiment, I guess, to do over the years. And as I look back over the outcomes that we achieved and obtained over the years, found that we were very often successful in this practice. So I share this with you today, and as we kind of tackle this brand new set of regulations and surveyor guidance that's coming our way, as a method and as a way to maybe think about how we're implementing these new requirements. So CMS has provided us with some job aids and some tools. This is one of the job aids from CMS. And you can see that the F tags are organized according to the regulation or the regulatory group that they're a part of. So this is good information and interesting information for us to understand where these F tags fall. I know this is small to see, and we'll provide the link to the resource where to find this here at the end. The problem with a tool like this is that it's very difficult to know how to implement it. So as providers, we can look at this and say, well, I understand, that this F tag falls underneath of this particular regulation, but what does that really mean and how does it tie into some of the other regulations? And so good information, but harder to implement. One of the ways that I've looked at this, and I know that other associations such as American Healthcare Association and Leading Age have also taken a more thematic approach to really looking to understand what these changes mean. And so I wanted to share with you some of the thoughts that I've had around how to look at these big themes. The first one is really related to the systemic and systematic approach to providing care and how you're how you're thinking about your business. And when I think about this, again, that taking into account that big circle, this is really the kind of the most all-encompassing component for us to consider. This is really, I think CMS will really be looking at how as a provider, how you're thinking about how you're delivering care in your buildings. So the next one is really, as we move into the circle here a little bit further, really is focused on facility assessment. Now, we'll talk in a little bit further about F838, which is the new requirement for the facility assessment. And this is really takes into account how the facility is planning for the care needs and the resources needed to provide care in your community for your residents. So when I think about this as a theme, I really think that this is about CMS and surveyors will be looking at how you're planning, how you're really planning for how you're providing care. I was talking to a provider the other day, and we were talking about this a little bit, and I said, I think my sense of this is that CMS just really wants to understand, and the surveyors will be looking to be able to see that you know what you're doing, that you're able to demonstrate through action, demonstrate through observation, demonstrate through interviews with residents, interviews with staff and family members, that you as a community and as a facility know what you're doing. And I think that's really at the essence of what the facility assessment plan is all about. The next area, I think embedded in all this is really thematically is competency-based care. Now, we hear a lot about competencies and skill checklists and that sort of thing. Competency-based care is really that ability to demonstrate how you're applying your plan, how you're applying your best practices, how you're applying the knowledge and the skill and the ability to really turn all of that into action in how you're delivering care. So there's elements of education in this. There's elements of supervision. There's elements of staff skill that will be required and are really thematically present amidst a number of the different regulations that you'll read and the guidance that you'll read in this new book of requirements. The next embedded circle, in a way, then to move into a little closer to the actual patient care, is related to person-centered care. Now, what I challenge providers to think about is this is really how your staff is demonstrating how you're empathizing with the resident. And providing, this is really the core of what nursing's all about and what the nursing process is all about, is really understanding what the residents' needs are, giving the residents opportunity to have voice and choice, and really seeing them as the locus, giving them that locus of control and that ability to really be an integral part of planning their care and directing how their care will be delivered. We get tighter into the circle here, and this is really where we're seeing quality of care, I think, that, the essence of how we're demonstrating our expertise. So quality of care bringing in those evidence-based practices, really being able to demonstrate that you're providing great wound care, for instance, that you're implementing best practices when it comes to reducing fall risk, that we're really assessing and treating and managing persons with urinary incontinence, and really understanding how to provide care to folks with cognitive impairments. There's a lot that goes into this quality of care element, and it's a really integral part of providing person-centered care. Finally, all of this is really ultimately leading up to the quality of life that the residents experiencing in your community. And I know that I've talked with a number of providers that are worried about this one. It's F675 is the F tag that will allow for a quality of life citation to be given. And the only way to get this tag is if the facility is demonstrating a pervasive lack of attention or implementation of care and provisions in other parts of the regulatory and the survey process. And so this particular focus on quality of life is really at the crux of all of this, and will really be a byproduct, again, of your work in all these other different systems and through these other different processes. So ultimately, it comes down to this, and I like this picture, and I wanted to share it as we move into this next section here, because I think this is ultimately what it's all about, is being able to see how we're impacting care that's being delivered to each and every resident that we're encountering in our daily practice. So with that being said, and under this lovely lady's watchful eye, we're going to move into the next part of our webinar session. I'm fortunate here at Direct Supply to work with a number of really terrific partners, and I wanted just to share just briefly that for those of you that maybe haven't had the opportunity to visit Direct Supply in the past, that there's really a nice opportunity, I think, for people to be able to get a lot of information. There's a lot of consultation that our teams do with providers. We work with thousands of providers across the country, and I think the real value of being able to share some of those best practices with you as well is something that we really are anxious to do. So with that, we're going to move into our first conversation today. We're going to focus and tie in a little bit closer to F584, which is really, the F584 is really safe environment. Now, I have also incorporated here some of the other language from F584, which is clean, comfortable, and home-like environment. And I wanted just to share the actual text from the reg itself, which it says the resident has a right to a safe, clean, comfortable, and home-like environment, including but not limited to receiving treatment and supports for daily living. The intent of home-like in this regulation is that the nursing home should provide an environment as close to that of the environment of a private home as possible. So this is always an area that our team finds itself, answering a lot of questions around. And so today I've invited Endl and Kari Harbaugh to join us today. JD and Kari are two of our senior product consultants. JD is our senior product consultant in our furnishings department, and Kari works with our healthcare equipment team. Thank you, ladies, for joining us today. When I look at this tag in particular, and I put a couple of points up here on the screen for us to look at, some of the elements that really pop out at me are topics like choice, preference, and control. How do we help residents feel like they have more of that when they're living in our communities? How do we provide for more of a comfortable and a safe environment? This tag also includes information on lighting, temperature, and sound, and this whole element of a home-like environment. So I know you get a lot of questions about these, and JD, I'm going to ask you first, actually, if you could, can you share with us some ideas of how you're seeing providers really approach this process of creating more of a home-like environment in their communities?
Sure, and I'd like to start by showing a picture of a resident room. So imagine that you are a resident or a family member. If you were placed in this room, how would that make you feel? Would you feel like you're at home? Ladies, what do you think? Would you feel at home in this room?
It's
No.
cleaner than my home. It's very cold.
It is. I think it's quite stark, when you look at the walls and how white everything is, and it feels kind of cold.
What about now?
Much better.
Yeah. So just with some very minor changes, you can make some big impacts. One of the big things I want to point out in here that's very little investment is the paint color. So adding a warmer neutral on the walls and then the accent color. The accent color is big. It makes a huge difference, makes it much more home-like, and it creates an opportunity to give the resident more choice. So you could have 2 or 3 colors that coordinate with your artwork, coordinate with your bedding and your lounge chair. So you don't have to change the furniture out, but give the resident the option of which color they would prefer in their room. Mm-hmm. Some other ways that you can give them choice and make it more personalized is by having a piece like what's on the left-hand side of the room there, the tack board and whiteboard. So you have a place to write notes. You also have a place that you can hang some family photos. So bringing in more of what you would have at home. There's not a ton of space in this room to have photo albums or picture frames laying around. So a place to bring in some local recognition, family members is really key. Mm-hmm. Another thing that we did in this room that is a little bit more of an investment, but if you have the budget available, updating your flooring can make a big difference in these rooms too. We're seeing a trend go much more towards the vinyl plank floors, so it's still very easy to maintain, take care of, but it looks a lot more home-like.
Mm-hmm. Yeah, I think too, it's interesting that there's still space in here. As a nurse, I always think about, where are we going to put the walker and where are we going to put the oxygen concentrator and where are we going to put, some of this other equipment. So you can tell that there's still some space in here, but it definitely does have more of a home-like feel to it.
Yeah, I like your point about giving the residents a choice, too. I think there's some other areas that we could give them a choice as well without costing too much or creating too much of a space concern for the community. They have reversible bedspreads. That's a really easy way to have, 2 options for a resident in one piece of one bedspread. Same thing with the mattress. There's mattresses now that have flippable firmnesses. So on one side it's firm, one side it's soft. Give the resident a choice in their own comfort, just like you're giving them a choice in their own thoughts on what they'd like their room designed as. Some other simple changes, I'm noticing there's a bathroom in this room. Shower curtains, that's something that it would be very easy to match whatever wall color they pick. A little bit more of an investment might be the hand towel, just knowing you might have to have different stock on hand, but it's another area where you could provide the residents with a choice. Mm-hmm.
Yeah, I think I do find that interesting because, and again, as a nurse, I think I'm always looking at like the clinical perspective and the practical aspect of it, right? Both from cleaning and from, you mentioned the mattress. And so, but I think what's interesting too is that we see such high quality mattresses now today that have that option or that choice, but still provide really great pressure redistribution. And I know we're not going to talk a lot about that today, but I think you don't have to sacrifice one to get the other, which I think is nice.
Definitely.
Yeah. Good. JD, I know you brought this picture, and when we were preparing for this, I was interested in this one in particular. Now, the size of the room is bigger, I think, than we might see in some typical communities. However, I did find this one interesting specifically because F584 calls out the importance of providing residents with privacy and their own closet and the ability to store more things. So can you talk us through what we're seeing here?
Yeah, so this is a great way to accomplish all of that with one piece of furniture. So the item in the center there is dividing the 2 rooms. And how do you create a home-like environment in a dual occupancy room? You have a stranger sleeping in the same room with you. So this is a great way to provide a lot more privacy and create more of a home-like environment with more furniture, but then also give more closet space. So there's a wardrobe in there, there are drawers, there's a ledge on top of the drawer, so if they do want to put photos or any personal items, they have space to do that now.
Nice. Yeah, it's a nice piece.
A couple more things I'd like to point out in this picture. On average, a long-term care bed is about 35 inches wide. This picture, we actually show a 42-inch wide bed. If we have the space, of course, and you have clearance all the way around, a wider bed is a great way to not only make someone feel more like they would at home, because very rarely are people sleeping on a twin bed at home. And actually, long-term care beds are about 4 inches more narrow than a twin bed, which a lot of people don't realize. But if we can bump out to 42 inches wide, not only are they getting a more comfortable sleep surface that they can actually turn and reposition without fear of falling out of bed, but it's much safer, of course, if they're not going to be as likely to roll out. And it's a great idea for the facilities to market too. You know, if you're standardizing on a wider, safer, more comfortable sleep surface for your residents, it's something you should be telling everyone that comes through your doors.
Yeah, interesting. Thank you for sharing that. JD, let's talk a little bit about some of the common spaces, and I know that you brought some examples here to talk with us a little bit about. Can you share with us some ideas about how to create more of that home-like environment in a common area, which oftentimes, I'll just share, again, just when I tour communities, oftentimes these feel more institutional, if you will. You know, they feel a little bit more like a hospital lobby versus someplace that feels more like a living room.
Yeah, and we're seeing a big trend go towards more of a hospitality or residential feel in these spaces. And the way that we're accomplishing that is by having multiple seating areas. So that not only makes the space more inviting and makes it feel less clinical, but it also gives the residents more choice. So when you think about living at home and going furniture shopping, you get to sit in 100 chairs and 100 sofas and decide which is most comfortable for you. Unfortunately, these residents don't have that option. But by providing different choices, so in this room as an example, there's 5 different chair styles, there's 3 different room settings. They have an option of not only where they want to sit and how many people they want to sit around, but also which chair is most comfortable for them in that room. There are still some things wrong with this room, however, as pretty as it is.
It still feels kind of cold.
Yeah, and it's very open. It's probably pretty loud in this space. It echoes. It's a very large space. So here's an after.
Voila.
Just the press of a button and your room looks like this.
Right, if only it was that easy, right?
So some of the things that we did in this space is add that wall color.
Okay.
You know, that'll change up a space, and it's such a little investment to add paint. So just a different color on the wall can really warm it up. The lighting can make a big impact on the space. So we use warmer light fixtures in here. We also, and again, this is a little bit more of an investment, but we changed up the flooring. So we added a carpet inlay in the center of the room, not only to define the space, but also to start absorbing some of that sound and to make the room feel a little less large. And then all the accessories that you see around the room make a big impact too. So the artwork on the walls, the accessories, you'll notice there's some silk plants in here. If you don't want to invest in live plants and have the maintenance of them, silk plants look great. And they really warm up a space, and you don't have to touch them. Even I could keep them alive, which is great. And then one of the other big impactful items in here are the toss pillows. So they're great for a couple of reasons. One, they can add the pattern, color, texture to the space, but can also make a difference between a chair being comfortable or uncomfortable. So a resident that's maybe a little bit shorter can put one behind their back and sit more comfortably in a chair.
Right. Yeah, some of those really simple little things, right, that you typically would see in somebody's house. But may not always see in a community. Some of it has to do with cleanability, right? I know in the communities I used to work in, and I mean, that was always a concern, that how do you keep things clean? And I know there's a lot of fabrics now that are easier to clean, and those types of issues aren't as much of an issue as they were, let's say, even 5 years ago.
Yeah, definitely investing in some protected fabrics. So any type of performance fabric, staying away from residential furniture, that's where you're going to have the issues with things not holding up.
Right. I wanted just to mention, too, or just follow up on something you said earlier about noise reduction. And we know that noise reduction actually can increase or impact the fall risk reduction as well. And so finding ways to, and minimize anxiety too. And so finding ways to reduce overall noise when you've got people living in a community, I think is really, really key. So you mentioned the flooring, but I think also the artwork and the drapery and that sort of thing that can also be help to absorb is what I've learned, what you've helped me learn.
Yeah, it's not all just about being pretty. It's very practical too.
Yeah, it's very functional as well, I think, which is important to know. Great. Awesome. Wonderful. JD, thank you so much. We've for talking us through the common area. I think we've got one more space, right? We wanted to take a look at the dining area.
Yeah, we'll take a look at the dining space. So this picture here represents your typical sea of 42-inch square tables. Not a lot of choice for the residents here. Very different feel in this picture. So we're seeing a lot more restaurant-style dining in these buildings, and it doesn't take a whole lot to accomplish this. So one of the big differences between this and the previous picture is the size of the tables. So when you go to a restaurant, you have your choice of if you're sitting with one other person, you sit at a table for 2. If you're sitting with 5 other people, you have a table for 6. So having a little bit more flexibility in which size table you sit and how many people you want to sit with. You can also give your residents more choice in menu options. So you'll notice little menu tents on these tables, giving them a few things to choose from so they feel like they have some sort of control over their dining environment.
One of the things I'd like to point out about this picture is the tablecloths. I think tablecloths can get to be a part of the everyday dining experience that can make a big difference if they're done right. A lot of people love the cotton tablecloths or the polyester tablecloths. They require a lot of care. There's washing them, there's trying to get the stains out, there's trying to keep these wrinkle-free materials from actually being wrinkle or to be wrinkle-free.
Right.
You know what I mean.
Right.
But what we actually have shown here are vinyl tablecloths. So don't dismiss vinyl tablecloths. They're not the old picnic table cloth.
The red and white check picnic table.
With the felt on the other side?
Yes,
Right.
that we used to always associate with vinyl. Some of them look great, and they're really easy to clean. You wipe them down, you're ready for the next service. Even if you're doing back-to-back tables or back-to-back seating, they can look good, they wear very well, and they're easy to clean.
Yeah, another component that makes it easy to clean are the seats and the dining chairs. So doing a vinyl fabric, we talked about performance fabrics. Vinyl is the easiest fabric to maintain and clean. So having that on your seats or your dining chair where all the sticky fingers and spills happen is the easiest way to keep the dining room looking fresh and keeping it easy on the staff to clean out and change out for the next meal.
Nice. Yeah. Yeah. I think, when you shared this image with me and even when we were talking about the other one as well, one thing that always comes to mind for me when I see a dining room is, are we creating opportunities for residents to be able to sit in the chairs while they're eating? And when I tour communities or I work in communities and I see dining rooms where there are very few dining room chairs in the dining room, what that typically tells me is that a lot of residents are coming to eat in their wheelchairs. And I think, when we think about, is this how the resident wants to eat? Versus is this more of a traditional practice of how we've provided dining or encouraged residents to come to the dining room in the past, is making sure that we're taking that opportunity to talk with residents about what their preferences are. Would they prefer to sit in a chair at the dining room table, or are they comfortable sitting in their wheelchair? And making sure that we as a staff haven't made that decision for them, that we're giving them the opportunity. I've worked with many providers that have implemented great walk to dine programs where they have, or something like it, where it's kind of an all hands on deck approach where the staff all kind of pitches in and helps residents with walking down the hallway and coming in and sitting at the table. So I think finding those types of ways to, again, integrate the practical aspects of these requirements with the home-like environment and really how we give residents more choice and control over their space is really important. So
Yeah, and another consideration, too, when you think about the residents that dine in their wheelchairs, is it because they are more comfortable in their wheelchair because the dining chair is too small for them?
Yeah, that's a good point.
A lot of our residents are not getting smaller, they're getting wider. And to be able to accommodate them, a lot of our customers are now including some bariatric chairs in their dining room. And what's great is that there are a number of styles available that are regular dining chairs and bariatric versions.
They look
so
the
it's
same.
the exact same chair, but now the resident is comfortable in a dining chair. You're maintaining their dignity. They are enjoying that dining experience way more than they had in the past.
Right, that's a great point. Good. All right. JD, thank you so much. This was really enlightening. I really appreciate you taking the time to come and talk with us today. So thank you. And you're going to come back a little later for some questions, I think. All right, thanks. All right, this time we're going to shift gears a little bit, and we're going to our next conversation is going to focus on the F tags that you see here on the screen. So F604 which is really the a resident around respect and dignity, and there's a big component of this related to restraints use. F700, which is a new tag, a new regulation around bed rails, and then F909, resident bed. So for this next conversation, I've invited Kari to stay with us. Kari's our resident expert when it comes to beds and mattresses, and she has been working with many providers over the years, for many years, on how to create better and safer bed systems in their communities. So, Kari, thanks for joining me. I'm going to turn it over to you here. I see you brought an interesting little image for us to kind of tee up the conversation here.
I did. So when it comes to these three new F tags, I'm getting a lot of questions around what do I do or what's the one bed rail that's going to keep me free from entrapment?
Right.
And I really have to encourage people to take a step back and look at all three of these, because it really is a three-headed monster. It's not just entrapment and it's not just the rails, but they seem to be the biggest talking point for most people. So to help us take a look at this and kind of break it down a little bit, we're going to take it in three steps: restraints, entrapment, and then the maintenance, which really boil down what those three F tags are about. Mm-hmm. So we'll see if we can
slay the dragon.
Figure out a way to slay this dragon. So first, let's talk about F604. This is kind of the beginning of everything, because everything snowballs from here. Mm-hmm. So making sure that if you have a rail on the bed, it is not a restraint. So this is very different than what we've focused on in the past, where we've said, okay, we're going to order one product, it's going to be this bed, it's going to have this rail, and it's going to be everywhere. That's no longer what we need to do. Everything needs to be individualized based on each individual resident. So to help us understand restraints as it's defined by CMS, let's take a look at what they say. So they say that a restraint is any manual method, physical or mechanical device, equipment, or material that meets all of the following criteria. So number one is attached or adjacent to the resident's body. Mm-hmm. Number two, cannot be removed easily by the resident. And number three, restricts the resident's freedom of movement or normal access to his or her body. So let's take a look at this in regards to a rail specifically. So is a rail adjacent to the resident's body? Mm-hmm. Yes, strike one. Can a rail easily be removed by the resident?
No, I've not seen one that can be removed by a resident.
No MacGyver residents?
Well, perhaps, okay. But yeah, no, not typically.
Not typically. Mm-hmm. So strike two on a rail. It really comes down to number three. Does it restrict the resident's freedom of movement? Mm-hmm. So what that's saying is, if for some reason this device is keeping a resident from getting in and out of bed, it is a restraint. You could have the exact same bed, rail, mattress setup for two residents. It may be a restraint for one resident, and it may not be a restraint for another.
Right. I think that's really a key point. And I think, as I've been talking with providers as well that are navigating that, we've heard from maintenance directors, we've heard from administrators that have said, help us, figure this out, because to your point earlier, they really had that different approach to managing. And so I really do think it's worth a provider's time to really give this the due diligence that's needed.
Definitely. So if we think about this as we lead into the next part, so you've determined that, okay, your resident can have a rail, and they have a medical reason to have a rail. It's not a restraint. That rolls us into F700 bed rails. Mm-hmm. This is where the entrapment guidelines come into play. And the good news here is the FDA entrapment guidelines have not changed. So they're exactly the same as they were.
In 2006, I think, right? When they first came out?
Hopefully everyone's been doing this for, years and years now, and you're all used to the entrapment guidelines. If you're not, please know there are resources available. This is an image put out by the FDA of what the 7 zones are. Zones 1 through 4 are the exact same dimensional guidelines as there have been since 2006. So those changes, so I should say there are no changes there, which is great. So nothing new to learn here, but know that anytime you have a rail on the bed, you need to take these into consideration. And I think another important thing to look at here is how do we do that? The FDA recommends an entrapment testing tool, which I'll show a couple images of one of those in some later slides here. But it's very important that we're testing beds all the time, anytime a change is made. And we'll get into that, which really rolls right into F909, the resident bed. And you need to take a look at how often you're doing checks and maintenance to these beds. It should be, as I started to say, anytime there's a change to the resident condition, we need to reassess. Anytime there's a change to the rail or the mattress, whether that's just everyday wear and you're starting to notice something, you need to recheck. Someone at the building has to be responsible for this, and that's really a key piece here, because if it's kind of falling between the cracks, you're going to have problems. So making sure that the facility has someone accountable and they're doing checks, that the equipment is being used to manufacture specifications. Seems obvious, but we have to make sure we're doing this. Does the mattress fit the bed properly? This is something that's becoming more of an issue because we've got adjustable frame beds now.
Right.
In the past, everything was usually 35 inches wide by either 76 or 80 inches long. Not a big difference as far as what we're seeing today, where you could see a bed that's 42 inches wide and a mattress that's 35. That's a huge risk.
Right.
The last thing I'll just mention on here is making sure that the bed rail is properly installed is going to help entrapment as well. The entrapment guidelines are an interesting animal themselves, because everything gets blamed on the rail. And the rail, as you look at what those zones of entrapment are, the rail itself is zone number 1, dimensions in the rail. Everything else has to do with how it works with the bed system. So this is an image of kind of what I was talking about before, a 42-inch wide bed with a 35-inch wide mattress. So I just put this together in our showroom to show you what not to do, and it's very clear here in the picture not to do this. But you can imagine if this bed is made and there's sheets and a comforter on there, it's not as easy to see. So making sure everyone in your building is trained. Of course, there's the responsible party, but everyone, whether it's housekeeping or maintenance or nursing, has to know to watch for these things. So making sure that everyone keeps a keen eye out.
I think, going back to that just for a minute, you made a good point earlier when we were looking at the environment, and where you were talking about that wider bed and how we are really seeing providers thinking about that from a resident choice perspective. And yet it's very common nowadays to see providers with different size beds, different size mattresses, all in one building.
Definitely.
And then given the amount of turnover that a lot of facilities have as well, that making sure that the staff that's coming in understands what type of inventory and how that all fits into managing that, from the facility's perspective as well, makes it really challenging. So this is a red flag point, I guess, and really one that can be a high risk issue to make sure that they keep an eye on.
Definitely. The next thing I wanted to point out is this is the entrapment tool I mentioned earlier. So this is the way to test your beds to ensure that they do meet the entrapment guidelines. The picture on the left, I kind of rigged up so that we could show how a mattress without a firm perimeter would fail a certain zone. So you can see how that entrapment tool got itself wedged in between the rail and the mattress. And that's a failure, and a lot of people are going to blame that on the rail. This is actually a mattress failure. So in the next image, it's a little difficult to see, but if you look on the side there of the pass, on the right-hand side, where it's hitting the rail, it's actually meeting up on a green part of the entrapment tool, which means it does pass. You can also tell that the entrapment tool is not sunk down like it was in the first picture.
Right.
And that really comes down to a mattress that has a firm perimeter. The firm perimeter is really key to helping prevent entrapment around the rail.
That's an excellent point about the mattress, and I think you're right. A lot of, in my years working in long-term care, a lot of times we would think about the rail or the bed and the space between it, but, the impact, we're not always thinking about mattress failure or mattresses getting old or having a breakdown there. So I think that's really important. Thanks for bringing that up.
Definitely. And I bring it up because, like you said, it comes up a lot. This is another one that comes up a lot, and many things get blamed for it. So the rail will get blamed because there's too much of a space between the rail and the mattress, or the rail and the bed deck. Well, if it's the rail and the mattress, there's a good chance that the only reason that space is there is because mattress retainers aren't being used on the bed. That's what's going to keep the mattress centered on the frame of the bed, so that it won't allow it to slide one side to another. This picture shows you what happens if you're not using your mattress retainers and the mattress slides. All of a sudden you can see there's a gap that opened up between the mattress and the rail.
Those come off all the time.
They come off all the time,
I see
yep.
providers take those off all the time. Or the CNAs have removed them because it's such a hassle to make the bed, and they put them up in the closet or they're someplace else other than on the bed.
Yes, definitely happens all the time. If you walk through your building and you know that you don't have mattress retainers in place, I think there's two things you should do. Number one, find out who you got the bed from, call them, see if they have replacement retainers you can use. Otherwise, they do sell straps that'll fasten the mattress to the bed deck. It'll still allow the bed deck to move and everything, but it's going to keep your mattress centered, which is going to keep from opening up some of those entrapment zones.
Yeah, that's really a good point. Important point.
So I know this is a lot of information, and we've kind of been talking about this three-headed monster. So I want to just maybe leave us with some takeaways, some best practices. So number one, assess the resident. If the rail is not needed, get rid of it. If we get rid of the rail, a lot of these other things go away as well.
We just move on to the next
We
thing.
just move on. It's much
well,
easier.
there's still other things to consider, but
There
right.
certainly is.
Doesn't
But
solve every, right.
It gets
But-
it makes the job easier
Well,
for
and
sure.
to that point, we joke a little bit about that, but we have seen a lot of providers move away from using rails or really not make rails a standard in their organization and really assess on an as-needed basis. So I think, we've seen a lot of providers, I think, just in the last few years really make that.
There are a lot of alternatives to having a rail. If it's a concern that someone is going to roll out of bed, hopefully that's not why you had the rail, but if it was, a wider bed might be a solution. We can't get into all these solutions because it would take another hour, but there's a lot of options and abilities to get some other things in place versus just a rail. So if the rail's not needed, get rid of it. If you determine that the rail is needed for a medical condition, the next step is assess for entrapment. Make sure that it's not just a rail situation, but you're assessing the entire bed system. So the bed, the mattress retainers, as well as the bed deck. And then, of course, gain consent from the resident. That's a really important part of the new FTIGs as well. And last but not least, repeat steps 1 and 2 all the time. Anytime there's a change to any part of the bed deck or the the bed system or the resident's condition, make sure you're rechecking. And the last point I want to make on this is keep in mind, a lot of times facilities will have hospice that brings in equipment. Your building is responsible for whatever is in your building. And if hospice brings something in and it doesn't fit with what your standards are, or you don't feel it's safe for the resident, you need to make that change and either ask them to bring something new or work to remove a rail or whatever the case may be, because it is in your building and you're responsible for it.
Right. Wow, Kari, that's a lot of information to share. Oh, look, we've got the dragon slayer that showed up because we've slayed this dragon, right? Really, thank you so much, Kari. I know you're going to stick around for some questions at the end as well. So thank you for joining us today. I appreciate it.
Thanks for having me.
All right, so we're going to move on into our next conversation here. This one is takes us down the avenue or the valley of F689, which is the new tag for accidents. So for those of us that have lived in the world of F323 for many years, we know that F323 encompasses a lot. There's a lot of elements to well, now F689, the old F323, that really speak to how we're keeping our residents safe, how we're creating an environment that promotes safety as well. These are all of the different elements that you'll see in F689, everything from resident smoking and resident-to-resident altercations all the way through falls and assistive devices, equipment hazards, and so forth. So essentially what it comes down to is that we've got an effective system not only for proactively identifying environmental hazards and the resident's risk for an avoidable accident, but also evaluates the resident's need for supervision or assistive devices. So this is such a big tag. And we decided to really kind of hone in on this one a bit to focus just on a conversation around fall risk reduction. And for our conversation today, I've invited Renae Buyeske to join us. Hi, Renae.
Hi, Liz.
Renae is our product consultant in our healthcare clinical category. And Renae is our kind of resident fall expert as well. So Renae, thanks for joining us. I know you spend a lot of time with customers when they come to visit us on campus and people that are really looking to change up their fall program and or implement some different interventions. Can you talk to us a little bit about some of kind of overarching things that you're seeing providers, I guess, kind of thematically, how they're thinking about fall risk reduction today?
Yeah, absolutely. So we're really seeing them think comprehensively and holistically. So versus focusing on a single intervention, really trying to work together with their whole team to understand what the risk is for each individual resident. So that's a key word, right? In a lot of these regulations, individual needs of the resident. Then working together with that team to really hone in on what that best practice is going to be to minimize that risk.
Yeah, that's so important, right? I think back when I was designing clinical programs, I'm going to say maybe 15 years ago or so, maybe some of the earlier 15 to 20 years ago, we really had a standard of practice where we called them fall kits, right? And where we had a little package they had a fall alarm and we had maybe a fall mat and we had, some other information, right? Some educational information and so forth in a little kit that everybody got. It was kind of a standard admission package, right, when people were admitted. Now, I think today we're still seeing a lot of providers take that approach in order to make sure that they're at least providing some good standardized information and education to residents. We've definitely seen providers move away from the use of fall alarms. And for the benefit of our audience today, if you've not read F689 yet, you'll note that there's a lot of information in the regulations around position change alarms. Is the term they use now is position change alarms. And that position change alarms can be construed as a restraint. They could be they are the path to being able to get to utilizing an alarm is much narrower, I think, for providers now today. So, which I think, as we see practice evolving and practice improving, the evidence just isn't there to really support, the widespread use of alarms for residents. So, can you talk to us a little bit about what we're seeing providers really focus on instead? So instead of, like you said, that really individualized approach, what are they doing? What is that really kind of first step that they're really taking?
Yeah. One specific area that we've definitely seen increase in interest is balance assessment and treatment. A lot of providers that are coming to see us are really trying to understand how do I formalize conducting those assessments and treatment using that equipment. We've seen observational assessment for a long time,
right.
For years by clinicians in the field, and those are great as well. But also utilizing technology and incorporating that together and using both now versus just observational, using that technology to get both together. Balance technology has evolved and it's come a really long way, so it really helps us better hone in on what that individual need is for that resident and what that specific area is that we need to focus on. So a great example of maybe doing a combination of two of those things is doing a time up and go test, so a traditional observational method that we've seen.
Yep, we've done those for years.
Yeah, and then coupling that with a piece of balance equipment to maybe get a balance score or understand are they weak to the left or the right. Putting both of those together can really help clinicians understand, again, that specific risk and then target exercises and programs around that risk and that intervention.
Are we only seeing those balance assessments? I've seen them a lot, or we talk to therapists a lot. I think that are using those or conducting those initial assessments. Are you seeing nurses using some of that equipment then as well, or providers that are talking about nurses using them too?
Yeah, absolutely. You know, and we see them a couple different ways. So first, an upfront assessment. So when the resident is first coming into the building, you know, really understanding what are your capabilities. Maybe they have no balance issues, and then seeing how that progresses over time. Are we staying with no balance issues, or are we starting to see an area, you know, that we need to focus on, as well as ongoing assessments for existing residents in the building?
Yeah, I think, you know, the addition of technology into what was once, you know, a subjective or, you know, more of that type of an observational assessment, I think has really helped to provide some very concrete ways to demonstrate improvement or decline then too, which I think is important. So let's talk a little bit about, I know that we've talked to providers frequently that will share with us, oh, my residents just don't like to exercise, and or they're, you know, getting them involved in exercise programs is sometimes challenging to do. I know I've flipped to your slides here because I know you got some interesting slides. Can you walk us through some thoughts here?
Yeah, absolutely. So a lot of the photos that we're seeing here is fun ways that maybe we can incorporate some of that exercise. So two of the areas that we're kind of seeing some focus on is first and foremost increase with the lateral stability and strength. So a way to maybe incorporate a fun activity would be dancing, something fun yet functional for them to kind of work on that left to right, you know, and side to side movement without them feeling like they're exercising or having to go to the gym and get on a piece of equipment. The second one that we really like to focus on is exercises that focus on quad strength. So even the simple act of sitting to standing and walking can really help increase that quad strength in those muscles in the legs. A lot of times when we see residents that are sitting in chairs all day, sitting in wheelchairs all day, you're really going to see the muscle mass starting to deteriorate, and they're going to be losing the strength. So again, kind of working together as a team to really understand how can we incorporate little things, standing, walking, increase mobility to really get residents up and moving. It's going to help increase that strength, reduce fall risk. You had mentioned earlier, Liz, a walk to dine is a great example of that quad strength. So it doesn't feel like formal exercise in the gym, but I'm not wheeling in a wheelchair, you know, down there. I'm getting up and I'm walking and I'm getting that movement.
Yeah, you know, and I think, you know, we're not spending time talking today about personalized care plans, but that is a very big part of these changes as well, is developing these comprehensive person-centered care plans. And I think that as providers are thinking about how they're incorporating what the resident really loves to do and tying that into a functional outcome, for instance, like dancing or walking or whatever, that are part of a fall risk reduction plan, so that the care plan doesn't just say, you know, place a fall alarm and observe that there's actually some, or goes to therapy and gets therapy so many times a week, but there's actually some additional things that they're doing incorporated throughout the day that activities department might be helping with, or the CNAs are helping with, that are all feeding into that that focus on reducing fall risk. And those are part of, I think, individualizing the resident's care plan that I think are going to be really important for providers to recognize and to take credit for in their documentation, so they can demonstrate that really person-centered focus. Yeah. So that's
Absolutely.
Great. That's good. Good. I know you have done some unique educational training, let's say, for providers that are looking for some new ways to train their staff, right? And so I know that you brought a few things to share with us today. So do you want to just walk us through some of those? I think you call them situational awareness, right? Like, how do we develop situational awareness in our staff?
Yeah, absolutely. So I have 4 photos to share with the group. And what we did is we went ahead and staged some rooms. So with some common and uncommon environmental hazards, the idea being that when you're walking around the community every day, you might miss some really obvious things that a photo might help capture. So if we move to the first photo here, we really focused on the common room area. So when we took this photo, again, we tried to stage some common and uncommon hazards that might be existing in a building. Some things that I like to point out in this one is the rug right in front of the gentleman's wheelchair. So perhaps too long, it's bunched so it's not laying flat and could cause trip hazard. The way that the furniture is positioned isn't allowing it to be more inviting for multiple people to join that area. Again, if this gentleman was wanting to enjoy the fireplace, chances are he would have to leave his wheelchair in order to get into that space comfortably, which could cause hazard. We, of course, see some of the water on the ground and an unmanned water bucket, and then some glare coming in from the windows, creating glare on the floor. So all things that we can notice that maybe we hadn't noticed before by simply just clicking a photo and hanging it up for staff to assess and put their recommendations on.
Right.
If we flip to an after photo, you can see that just by some simple changes, rearranging the furniture, for example, to leave some bigger gaps for either a wheelchair or even a walker and cane to get through and get into that common space, putting a wet floor sign out so that we're advising people to be more cautious in that space, and then you can see a staff member there. So it's creating staff engagement into the actual room itself while a resident is there.
Yeah, interesting. That's good.
Finally, we took a look at a resident room. So another really popular room, that we can take a look at. So yeah, just like Liz said, yikes, right?
It's pretty, but it looks really unsafe.
It really does. So, some obvious things that we might see, the blanket, being draped on the ground, so a trip hazard. Some personal items aren't near the bed, including that walker. So if I was more dependent, if the resident was dependent on using that walker, they have to travel quite a distance, say from bed or chair, in order to get that assistance. We see the floor mat being used not appropriately by the bedside. It's not positioned appropriately and maybe left out when it shouldn't have been, and just a lot of clutter. So there's a lot going on in that room, which makes it really hard to navigate around that particular space.
Yeah, and life just happens, right? Like we were talking earlier, you end up with a bunch of stuff in a room. And I think one of the interesting parts of an activity like this is if you take pictures in your own room or your own community, it's kind of like, you drive by the same thing every day and you don't notice it, or you walk by the same pile of papers in your house or whatever it happens to be, and you just don't notice it. And the same happens with caregivers. They walk by the same common space or walk by a resident's room, and so taking a few moments to snap a few pictures and to use them for educational purposes, obviously with the residents' consent, but to photograph their space, but can really be impactful, I think, in helping staff recognize where there's opportunity for improvement, for sure.
It also, Liz, is a good way to get the whole team involved again. So it doesn't have to be an activity just for nursing.
Right.
Like you said, with resident consent, if I take this photo, maybe I hang it up in a space where I'm getting a variety of staff and opinions, maintenance, housekeeping, administration, nursing, rehab, and all of those, working together to really be able to identify and pull out different things that others might miss.
Right. Yeah, I know we've seen that ourselves, haven't we? I know you have for sure when you've done this activity with different groups, so yeah.
If we look at the after photo, you can see just immediately, it kind of gives you it feels better. So immediately we notice more space. You can tell that there's bigger areas to allow for walking, getting that walker through. The walker is now positioned by the bed and the chair, so depending on where they were sitting, they can access that easily. And then we see better use of a deluxe bedside mat. So something shorter, something that's going to have beveled edges and stay to the ground itself, making it a much safer space for that resident.
So can you talk a little bit about fall mats? Because you know how I kind of feel about fall mats. I was worried that they're adding to fall risk, and yet we still know that providers, that there's a need, and providers like to use them if there's concern with rollout and so forth. Can you talk a little bit about what are some of the trends that you're seeing providers and how they're thinking about fall mat use?
Yeah, so one trend we're seeing is the mat that you see here. So the mat that we see in the photo is a deluxe bedside mat. Not only does it help give you a more home-like feel to a lot of the slides that Kari and JD were speaking to, but it's really giving you an opportunity. It's a shorter mat, so it's not extending past the end of my bed, so perhaps not causing risk if I'm walking around the room. Again, the beveled edges, so it's not causing a trip hazard. And a big trend that we're seeing now is that the mat is pulled out when we're in bed to help reduce injury for like rollouts and things like that. And maybe during the day when they're not in bed, it's pulled under the bed. So it's out of the way. Yep, we slide it under the bed. So it's out of the way and it's not even out on the floor at all.
Right. Are those pretty easy to clean then?
Yep, very easy to clean. Yep, okay. So it's got a carpet-like texture, and any machines can be used on that you would traditionally see in our EVS space on the carpeting that you have in your building.
Very good. Interesting. Okay, good. Well, that's so interesting, Renae. And when we think about the environment, it's not just about, some of the equipment, but creating these spaces that feel comfortable and the residents are, have their stuff. And sometimes their stuff creates risk for them as well. So it's just finding all of that right balance, right, of how we can help residents really have the things that they want to have in their room, but keep them safe at the same time. Good. Renae, thank you so much for joining us today. I really appreciate it.
Thanks.
Okay, we are, for our final part of our session today, we're going to be talking about F838 facility assessment, and specifically within that assessment, the requirements around e-tags and emergency preparedness. In order to give us a little bit of insight into this, I've invited Ray Miller to join us. Ray is the Director of Risk and Safety Solutions here at Direct Supply. Ray is, for many of you, I think if you've attended one of our webinars in the past or have heard Ray speak before, Ray is a great speaker and a huge advocate for our communities that we work with, and has been doing a lot to help providers prepare for the new emergency preparedness tags, which is a whole new set of additional tags now with these new e-tags that are upon us. So in addition to having all new F-tags that providers are having to deal with, now they've got this whole other new set of e-tags to worry about as well. So I think one of the interesting things I've been hearing Ray talk about is really making sure that as providers that you're not reinventing the wheel when it comes to integrating emergency preparedness into your facility assessment. And depending on what type of a provider that you work for, if you're an individual owner, independent owner, or part of a big multi-facility corporation, there may be different people involved in helping to prepare your facility assessment versus preparing your emergency preparedness assessment. And so I think it's really important to make sure that we're integrating and not creating more work for ourselves than is necessary. So with that, I'm going to turn it over to Ray, and this is going to be a little bit different. Instead of a conversation, Ray is going to share with you some of the slides from his emergency preparedness session that he's done for providers. That's really, a 2-hour session, I think, right? So Ray, in about 20 minutes, is going to give us kind of a condensed version of this and the parts that are really necessary for us to focus on related to the facility assessment. So with that, Ray, I'll turn it over to you.
Thanks, Liz. And before I shift over to the slides, I think it's very worth noting a comment that Liz just shared with you, and that's the fact, the importance of the integration. The requirements, the federal requirements, do not mandate that you throw everything away that you've been doing. You've probably been doing very good things. What they want you to do is an analysis and look for gaps. And so that's really what we're talking about, and how are we going to do this? So there's a final rule. It applies to those who are Medicare and Medicaid participants, and it's been talked about for quite a while. There's 17 different care providers that are covered by this rule, but it's not assisted living, obviously. So when you go through things like the interpretive guidelines, there's not nearly as many interpretive guidelines as what Liz had to go through for the conditions of participation. But there's still 77 pages, and they are spread out covering all 17. So it's helpful when we can boil it down to those that apply to you. And so that's what we've done with this presentation. The original publication was middle of September 2016. They actually gave you a couple of months warning with this so that you can start reading it, knowing that the effective date was in November, the middle of November of 2016. They expected you on that date to begin to incorporate these things, and the implementation is upon us. It's in just a couple of weeks. And the reality is, they're on the 15th of November 2017. They expect you to be survey ready, and that means in full compliance. And so hopefully there's been a lot of work going on, but again, it's not to replace everything you've been doing, but to incorporate, figure out where your gaps are, and then move forward with that. And those interpretive guidelines that I referred to are actually referred to as Appendix Z. So what is the purpose of this whole behemoth? Not nearly as big as what you're already dealing with, but it's one more deck of cards to shuffle in with a big stack. The whole idea behind it is that you're able to plan. Now, in this planning, you have to have knowledge, and the knowledge comes from doing all hazards assessment so that you're able to identify where your risks are, where your vulnerabilities are, where your gaps in your policies and procedures. So you're going to take a broad spectrum look. You're not just looking within the walls of your community, of your facility. You're not looking within the grounds. You're not looking in the immediate neighborhood. You want to reach out. If you go back just a couple of years, not even 2 years, I don't think, to that chemical plant that caught fire and exploded in Texas. It was 20 miles away from the nursing home, and they had to evacuate. They lost no residents, which usually that doesn't always happen. But they didn't lose any residents because apparently they were prepared for this. They had practiced, they had discussed, they had written, they had trained. And so the other piece, besides the planning side of this, is now you need to be able to coordinate. And that's coordinate with two fundamental groups. The first group is that you would coordinate with your authorities having jurisdiction, your health departments, emergency and disaster preparedness offices, your fire departments, all of those individuals. But then there's also another group they want you to collaborate with, and that would be with local hospitals, other nursing homes in the area, and those kinds of groups. And so we'll talk about this in a little more detail and give you just a little bit of a visual image because I think that's helpful for us just to wrap our arms around this. They want you to prepare to meet the resident needs. Another way of thinking of this is if you think of continuity of operations. Operations being the care that you provide to the residents and all of the various aspects that need to be in place, the different policies and procedures and practices and resources and all of those kinds of things that lead up to high quality care and a quality of life. The reality here, though, is the fact that you've got to be able to deliver that regardless of the situation that you're aware in. Liz and Renae were just talking about situational awareness, and I think that really applies here too, because if you're in the process of having to evacuate, and you're in your buses or your ambulances, and you're moving down the highway, know that you're not going to move fast because you're not the only one trying to evacuate, and you have a resident that requires dialysis. It has to be built into your plan so that you can continue to deliver that kind of care as well. You need to know where the stops are. You need to have pre-arrangements. Those kinds of things need to be built into your plan as well. The reality for all of us is that these sets of requirements that have been rolled out to us are not new. They have been in place in the hospitals for some time. And so they have been proven, they've been tested, and that's one of those groups that you want to be able to reach out on the collaboration side and begin to work with them. There's 3 essentials you need to be able to deliver. And there'll be no surprise as you read through those. One is for people. You've got to be able to take care of the residents and your staff and anybody else that's there with you, the volunteers. You've got to be able to take care of the delivering the care. And then you've also got to be able to take care of your physical plant. Those are the 3 of the essentials that you need to keep in mind. So the way the rule reads, the way the regulation reads, is the facility must comply with all applicable federal, state, and local emergency preparedness requirements. So we're not saying that the federal requirements displace the state requirements. If you've got a state requirement that's more stringent than your federal requirement, you've got to be in compliance with that state requirement too. So you still need to stay very well educated on what your state requirements are, stay engaged with your local emergency preparedness office and those kinds of folks, because that's going to help you deliver everything that you need to as far as the requirements go. And then you've got to meet at least these pieces. Okay, you see 6 of them. Now, the reality is, if you come down through there on number 2, policies and procedures, there are 10 other policies and procedures, that very specific policies and procedures that you need to have. And then when you go down to, when you get to the area of either sheltering in place or evacuating, there's 11 more that you need to have in place. But that's all spelled out for you. And we'll share some documents with you as we go through this as well. Now, when Liz talks about the new tags, yes, you still have your K tags. You still have your F tags. I always forget that. It's not my area of concern. It is. I'm just kidding. Your F tags, your K tags, but you also have E tags now. And we'll provide a little a one-page brochure that lays them out, defines them for you, and lets you keep your arms wrapped around them. Another set of resources for you that you'll receive when you get the PowerPoint itself is a series of links. And you'll see at the bottom of the page that we always tend to footnote our pages and give you the sources and hot links so that you can go out there. This is actually from the federal website for emergency preparedness. And so you can see, for instance, you see 5 frequently asked questions. I've read through them. Very educational. Some of these things, it's sort of surprising that they weren't in the original document, but they aren't. So you have every opportunity to ask questions, to get feedback. And if you see the second line on this slide, it says for questions regarding EP rule. It gives you a website address to send your questions to. And that way CMS does respond. They get added to the FAQs. And it's a good way to get very, very current and absolutely accurate, as good as the federal government can give. Am I allowed to say that?
Yeah.
Okay. But that's a good way to get answers to your questions. And I wouldn't hold on to them. If you're part of a corporation, you ought to spread those answers out. Now, another tool that we're providing for you is we've taken the actual verbiage from the regulation itself and dropped it into this document. And if you look at the third column, you'll actually see where each of the E-tags are listed, the applicable E-tags. So this enables you to go through step by step and figure out where you are so that you know who's going to, and then you set a SMART goal for it. Who's going to do it? What are they going to do? When is it going to be done by? All of those kinds of parts and pieces so that it's achievable. And this will be provided to you as well. There's another piece that I've inserted here, not because I've seen it be so extraordinarily effective, but it's one I'm hoping for. This is actually a fairly new piece in terms of its applicability because this document actually spells out the responsibilities for your ombudsman in the area of emergency and disaster preparedness, which is kind of an interesting approach. I'm glad it's here. They have canned PowerPoints and handouts, and the handouts are for families and for residents so that they know what their role is, so that they're not surprised if there's an evacuation or there's a sheltering in place, so that they have that kind of information too. Now, I've presented for many different states, and the reality is we're not seeing a lot of action on this just yet. My sense is it will begin to happen, but it's something for you to be aware of, and this is about a 6.5-page document, has a lot of detail on it, and it's worth being aware of. Now, here's that little mental image that I wanted to provide for you in terms of your coalitions, okay? And I'm going to put some 3 boxes in there. And when you look at it, and I got to put my glasses on, so forgive me. Yes, I'm getting old. So we have public health department. That's right around 4 o'clock. At around 5 o'clock, local government. And then at around 7 o'clock, emergency management agencies. Those are the ones that you're required to be in coalition with you, to communicate with them. There's even a requirement for your emergency management agencies that you literally talk to them at least once a year, tell them what kind of surge capacity you could provide, tell them the conditions of the residents that you currently have and their needs, all of that kind of information. Now, I would also recommend, and it's required quite honestly, that you document all of those efforts and all of that information that you send out so that when you are surveyed, you will most likely be asked for that kind of evidence. So make sure that you write it down, that you store it in a retrievable fashion. And then your collaboration, that's everybody else in the circle. Okay, those are the ones you want to reach out to. Keep in mind, reaching out to the hospitals, they've been doing this for a while. They've learned a lot of lessons. You don't need to make all of the same mistakes in order to move forward without making mistakes. Learn from somebody else. There is in that sheet that we provide, that we showed, one of the resources where we had all of those links on there. There is a link, and I think it's the second one down. It was updated July of 2017, and it's a list of all of these, and they refer to it as the integrated healthcare system. And it's everybody in your area. It's by state and by county. So if you go out there, you can figure out by county where are these collaborative groups. You're going to run into 3 different kinds, though. Those who are really good at it, those who are trying, but they've got more to learn, and some just haven't even gotten started yet. Don't back away from those that haven't gotten started. Start prompting and prodding, because even if they haven't gotten started, they've still been living by these regulations for a while. There's a lot to be learned from them. Next to the last item, 1135 waivers. The waiver, the title actually comes from the Social Securities Act. And it's extraordinarily important to you because you see the 3 steps that have to happen. 1, President declares major emergency or disaster. 2, the Secretary of Health and Human Services declares a public health emergency. At that point, with those 2 steps in place, that same secretary is now enabled by under law to issue an 1135 waiver. And this is extraordinarily important to you because in an emergency situation, staffing can be such a challenge. Even issues with HIPAA and some of those kinds of things. And even if you look at the second one that just popped up, Medicare Advantage out-of-network providers. In an emergency, you may not have the specific provider that you need to have. But this is a list of the kinds of things that they will waive with this 1135 waiver. So you give the care. You've stayed aligned with these waivers, and you can still get paid for all of the expenses and all of the work that you've done. Extraordinarily important. My recommendation to you is stay engaged with your state and your national associations because they're going to help you with this. They're going to prompt you. They're going to send them out to you. They're going to help you understand them. Last area. You can see all different kinds of emergencies, if you would. Hazards, nasty things going on, whether it's hurricanes, tornadoes, floods, nuclear power plant, volcanoes, all of those kinds of things. You're supposed to know what's going on in your area with each of those things. You need to not only determine what they are, but you need to be able to rank them. And we'll talk about how you rank them, all right? You need to figure out what's universal. What's universal? It could be an elopement. Because we have for years been required to have an elopement policy as part of our emergency, a resident elopement for emergency and disaster preparedness. But we also want to think about the one I've already brought up, and that was that chemical plant. What's going on in your area? I've got a picture I often use, and it's a tire recycling plant in Southern California that's on fire, okay? If you know it's there, you can prepare for it. You can build that into your plan. You know what's going to happen. But you've also got some unique ones. And I always tend to point out a title. It was a beautiful facility. I'm not going to tell you where. I'm not going to tell you who. But it was a beautiful facility, but it was named Lakeview. And as a risk guy, I'm sorry, that name makes me nervous. I'm absolutely, I've determined that there is an eloped resident magnet in the bottom of that lake. Okay? And they're all going to get drawn to the lake. So that kind of stuff makes me nervous. But what else is unique to you? Do you have a railroad spur that's close to you? Are you indeed close to a freeway? Is there some sort of a manufacturing concern with something going on? And you're saying, I don't know. Go talk to your hospital. They have to have this too. They've done this for a while. Work with them. Collaborate with them, okay? And when you think of it, you're going to figure back to, okay, what am I located next to? What can I learn from history? And in terms of near proximity, you can be real far away from a nuclear power plant, and if there's a problem, a change in the prevailing winds, and you now suddenly are much closer to it than you were before. So, but we're going to measure each of those with 3 words: probability of occurrence, the risk or the severity if it occurs, and then your preparedness. So we're going to share this document with you. It's one of many documents out there. It's one we put together. We actually learned a great deal from the Georgia Healthcare Association document. We're grateful for all the work that's been done by others. And I'll give you a link at the top because even now, just a little bit ago, CMS has now published a toolkit. And in there are a variety of documents. There's some boilerplate documents in there. There's also a hazard vulnerability analysis that you can use. So it doesn't define which one you use. It only defines that you need to use one. So I'm going to grab those, the second, third, and fourth column titles, and just bring them down here. And you can see the words again: probability, risk, and preparedness. And it's a ranking. I mean, you take a look at the probability of, let's say, volcano in Florida. It's probably none. Not that we can say none very often, but it's probably none. So that's not going to be a big deal. How about hurricane? That's a 3. And if you come across to that second one, if it does happen, how big is the risk? It can be life-threatening, so 3 times 5. Now comes the big factor. How prepared are you? If you're prepared, that 3 times 5, you're going to only multiply it by 1 because you've got a good, solid, planned, trained tested program. But if let's say you are a brand new building, you got brand new staff, be very, very careful claiming to be a 1 at that point. Because you can always back up once you've done some drills and you've done some exercises, and there is a difference, and you need to be aware of it. It's not part of this presentation, and I apologize for that. But there is a recording for the 90-minute webinar that we did for TELS that you have access to, and you can get much more of that kind of detail. So once you've practiced, you've got everything in place, the people are ready, now you can multiply that 15 by a 1, whatever your exposures are. And then you have this total number, and you go ahead and prioritize them. All right, it's one of those TELS handouts. There's a list of some other hazard vulnerability analysis tools. The Kaiser Permanente is out there. You actually have 2 versions, 2014, 2017. Please consider using the 2014. It's a little easier to use if that's the direction you need to go in. But even if you've used one of these other tools and you've completed, we're not saying to redo it. Use what you have so that you can move forward in an expeditious manner. It saves lives. You save lives. You're heroes. Thank you.
Ray, thank you so much. I appreciate your time and all of the energy and effort that you've put into this education. I think pulling these tools together and making these things available for our providers are just so critical. That, along with the rest of the information that was shared today, we've got some resources that are listed here. These are the CMS resources. That you can find in addition to some of the slides that Ray showed and Kari showed that had some additional resources on as well. So we've covered a lot of information today, covered a lot of ground. I think ultimately I'm bringing back our resident here to join us here under her watchful gaze. We're going to take some questions. I know while Ray was speaking, Robin, you said that we've got a few questions, so we'll turn it back over to you.
All right, thank you. Ray, how often does the facility assessment and emergency prep plan need to be revised?
It says at least annually, but if you make some sort of a significant change, or perhaps a new plant is built close to you, or you add a wing, or any of those kinds of things, even if you add some sort of a daycare concern, to help your staff with some child care while they're there at work. Those kinds of things would cause you to back up your plan and to make your changes, but at least annually. But it's kind of like with residents or any change of condition.
Yeah, we were talking with a provider the other day that's looking to build a vent unit, an add a vent unit. If you've not cared for patients on ventilators before, it's not just a care-related issue that you're needing to prepare for, but there's also additional emergency preparedness types of things you have to think about now as well.
And there's lots of stories in emergency situations with vent units. There's plenty of preparation that you need to make.
Right.
So absolutely good example.
Mm-hmm.
Thanks, Ray. JD, you talked about providing resident choice in room design. When does the resident get to choose those designs?
It's really up to you. Depending on, when the resident when you determine if they're going to be staying long term, they could definitely make that choice at that time. Or if you want to just divide your rooms by 3. If you have 3 different colors and divide them by 3, and then when the resident comes, you can just pick which one. Obviously, that has its own hurdles to cross. But typically, it doesn't take much to quickly paint the room if you want to do it as you determine the residents are staying there.
Great. Renae, this question I think is for you. It talks about that they have a lot of falls that happen in the bathroom and wondering what they can do to help prevent them.
It can be a tricky space, especially in a lot of buildings that Liz and I have had the opportunity to go to. They're typically not the large, spacey bathrooms. So trying to think of items that are going to help in a small space the resident accomplish tasks without another physical body being in the room. If we think of a shower, think of things like the anti-slip matting in the bottom of the shower itself, perhaps a shower bench if they're going to fatigue and not be able to stand the whole time while doing that activity. And also then coming to the actual toilet itself, a toilet riser. So something that's going to help them do that sit-to-stand motion easier from a higher spot, versus the actual toilet itself.
There's so many options now, too. I think that as a former provider, and we had just I always thought there were kind of some standard toilet riser options, but there really is a lot of choices out there now in different, colors and, lighting and that sort of thing then too. So that adds some different variety to it.
Yeah.
Mm-hmm.
All right, I'll take this question. It says, will all of the websites and tools be available in a handout or list format? And yes, the slides that you saw with the resources listed, those will be linked on an email that will be sent out tomorrow. And so you'll be able to access all of those in the presentation link. Liz, this question I'm going to give to you. It says, this feels so overwhelming. Where do we start?
Let's see.
I'm glad you got that.
Well, first of all, it is overwhelming, and I do think that back to what I mentioned earlier about having a plan. I think getting your team together. I've worked with so many directors of nursing, and for those directors of nursing that are on the phone out there right now that feel like all of this has fallen to your shoulders. Get your team together, rally your team, make sure that this is an interdisciplinary team approach to addressing these issues. And I would really encourage everyone that's listening to, back to that kind of initial formula that I shared with you, is really concentrate on focusing on doing the right thing. So look at what the evidence says, look at what best practices say, look at what is going to get you the best clinical outcome, and then look to those areas within that you can start to modify your risk, minimize risk related to documentation. For instance, if there's opportunities to reduce redundancy in documentation. I know providers that have done just a tremendous job in reducing risks associated with just the time involved in just documentation alone by kind of reevaluating their whole documentation system. And focusing on ease of use and really helping to teach your staff the way that you're thinking. Ray and I talk a lot. I used to work with, I've shared this with him, he and I have talked about this before. I used to work with an administrator years ago that one of his strategies for teaching his staff was just to take a different staff member on rounds with him every day. So he'd walk the building and he had a list set up a calendar set up of different staff members. He came in at different shifts, and they would just partner up and they would walk the building. And while they were walking the building, he would teach the staff member what it was that he was looking at. And as a result, what he was finding and what we found, and we actually replicated that process in other communities, but what he was finding is just that simple act of engaging with his staff, that simple act of walking the building every day, which he had to do anyway, but taking somebody with him and teaching them how to look at what he was looking at. And he was also learning from them to look at things that he hadn't seen before either. So it was a way to start building a competency in his staff that was already part of an existing process that happened, and it was such an effective and yet simple way to do that. So I would just share, the old saying goes, how do you eat an elephant, right? One bite at a time, and just. Not as funny as some of the jokes that Kari likes to tell sometimes, but one bite at a time. And I think that's a really important way to go about this. If you have questions, please reach out. There's so many resources. I think in addition to the resources we can offer here at Direct Supply, your state associations, the national associations, American Healthcare Association, Leading Age, others have really done a great job of providing additional educational resources as well. So make sure that you're really taking full advantage of those. Probably a longer answer than the caller was looking for.
That's perfect. Thank you so much to Liz, Kari, JD, Renae, and Ray for all their valuable information. For more information about our upcoming webinars or to view past webinar videos, please visit directsupply.com/webinars.